The patient with a disability, wheelchair transfer. Always inform the patient of intended actions before starting. Ask patient, parent, or caregiver the preferred transfer method and ability to help with the transfer. Selection of a transfer technique is influenced by the size, weight, and mobility of the patient, along with any special physical conditions and patient's preferences. The patient may prefer to transfer from the left or the right side of the dental chair, depending on which side of the body is stronger. Transfer from the wheelchair can be a frightening experience to the patient owing to fear of falling and injury. The preparation for wheelchair transfer. Clear the area. Before starting a transfer, clear the area. Move the clinician's stool, bracket tray, foot controls, and operatory light. Remove or move the operatory chair armrest out of the transfer area. Special needs of patients. Chair padding. Special padding is used in the wheelchair as protection from pressure sores. Depending on the length of the appointment, the patient will decide whether the padding is moved to the dental chair. Pressure sores or decubitus ulcers are usually in the buttocks area. Bags and catheters. For patients wearing a urinary or colostomy bag, care must be taken during transfer and after transfer to ensure tubing is not bent or twisted. Spasms. Ask the patient about susceptibility to spasms and about procedures to follow the prevention. Advice concerning transfer. Ask the patient, family member, or caregiver how best the clinician can help during the transfer. The patient is allowed to do as much as possible. Transfer of a patient who can assist. When a patient can support his or her own weight, the stand and pivot technique can be used. Position the wheelchair. Face the wheelchair in the same direction as the dental chair at approximately an angle of 30 degrees. Set the brakes and remove footrest and wheelchair armrest. Prepare a dental chair. Adjust the chair to the same height as or lower than the wheelchair. Clear a path for transfer by lifting or removing the chair arm. Always have a second person in the treatment room to help if required. Approach to patient. Support the person while detaching safety belt if present. Face the patient and place the feet outside the patient's feet for pivoting. Clinician's knees are placed close to or against the patient's knees to prevent buckling. Place hands under the patient's arms and grasp the waist belt in the back. Patient places arms around the clinician's neck or places hands on the wheelchair to push up. Clinician lifts patients to standing position. Pivot to dental chair. Pivot together slowly until the patient is backed up to the side of the chair with the backs of the legs touching. The patient is gently lowered to a sitting position. Reposition the arm of the chair. Grasp the patient's legs together between the ankles and knees and lift them onto the chair. After the wheelchair transfer, release the wheelchair brake to move it to a side. In a small treatment room, the wheelchair may be folded and set aside. After the appointment, return the patient to the wheelchair in the reverse order of procedure. Transfer of a patient who is immobile. When the patient is unable to support his or her own weight, 2 aides are required. The parent or the other caregiver may serve as a second person. Never attempt to do this alone. You position the wheelchair. You position the wheelchair in the same direction and parallel with the dental chair. Set the brakes and remove the footrest. Adjust the dental chair to the same height as or lower than the seat of the wheelchair. Move the arm of the dental chair out of the transfer area and remove the arm of the wheelchair. Clinician 1 is positioned behind the wheelchair. Help patient arms across the chest. Will place arms under the patient's upper arm and grasp the patient's wrist. Clinician 2, face patient and place both hands under the patient's lower thighs. Transfer. On a prearranged signal and steady motion, Clinician 2 will initiate and lead the lift. Both clinicians should use their leg and arm muscles to lift the patient's torso and legs at the same time. Gently transfer the patient to the dental chair, secure patient in chair, and replace armrest. Repeat in reverse. After the appointment, the patient is returned to the wheelchair in the reverse order of this procedure. Sliding board transfer. A patient may bring a sliding board or one may be kept in the office or clinic. A transfer board is helpful for the patient. 2 persons are recommended during transfer and are required when the patient is heavy or less mobile. Position the wheelchair. Position the wheelchair in the same direction as and parallel with the dental chair. Set the brakes and remove the footrest. Adjust the seat of the dental chair to slightly lower than the wheelchair seat. Move the arm of the dental chair out of the transfer area and remove the arm of the wheelchair. Adjust the sliding board. Patient or clinician places the sliding board under the hip of the patient. The board is extended across the dental chair. Transfer. Patient shifts weight, balances on hands, and walks the buttocks across the board. The clinician can assist or do the transfer by holding the patient under the axilla or the armpits. The board is removed and replaced after the appointment. Repeat in reverse. Dental chair is positioned slightly higher than the wheelchair seat for a return of the transfer. Wheelchair used during treatment. When the patient is in total support, wheelchair transfer to the dental chair may not be advisable. The wheelchair can be positioned for direct utilization. Some wheelchairs are self-reclining and have a headrest. A portable headrest may be attached to the wheelchair handles. The dental chair can be swiveled to permit the wheelchair to be placed to the dental light, can be directed into the patient's oral cavity. An automatic wheelchair lift that tilts the chair back can be obtained for a clinic facility where patients in wheelchairs are frequently visited. Instructions for the caregivers. Individuals who need partial or total care present with varying degrees of ability to cooperate depending on the type of the disability. The size of the patient and the wheelchair, the patient is ambulatory, bedridden, or in a wheelchair are among the factors that influence the technique for management. The instructions for a caregiver are given where the specific techniques can actually be demonstrated as they will be done at home. Time and repeated practice sessions may be needed for successful biofilm removal. Self-care and attitude. Whenever possible, instructions for the person's family members or other caregivers begins with their own personal oral care. Success comes when those who care for the patient have knowledge and understanding of the purposes and the techniques. General suggestions. Place. The biofilm removal procedures are accomplished best when both the patient and the caregivers are comfortable and relaxed. A small bathroom may be the least desirable place because positioning the patient may be awkward, except when standing position can be used. Good light, easy visibility of the teeth, and control of the head and the person with the disability are prerequisites. Teaching technique for biofilm removal. Use of finger rest and hand rest. The person performing the biofilm removal balances the toothbrush, dental floss, floss aid, or any other implement with a finger or hand rest on the side of the patient's face or chin. Such contact contributes to total patient control and to effective use of the biofilm removal device. Use of a mouth prop. For certain patients, biofilm removal is impossible without a mouth prop, and demonstration for insertion on both sides is needed. For home use, a rolled and moist washcloth may be appropriate. Positions. Caregiver standing. With the caregiver standing from behind, the arm is brought around the patient's head and the chin is cupped while using the thumb and index finger to retract the lips and the cheek. The other hand applies the toothbrush, floss aids, or other devices. This technique requires the patient to be able to be behind the head back far enough for the patient to see the maxillary teeth. The procedure may be applicable for the following: short patient standing in front of and backed up to the caregiver, tall patient seated in a chair with the head tipped back to lean against the caregiver, or seated in a large chair or sofa with the head stabilized against the top of chair back. Patient in a wheelchair leaning back against the caregiver. Wheelchair brakes are set. The caregiver seated. Patient seated on a pillow on floor in front of the caregiver with back close to the chair and head turned back into the caregiver's lap. The caregiver may place his or her legs over the shoulders of the patient to restrain arms and body movements. Caregiver is seated at the end of a sofa or couch, and patient is lying down with the head in caregiver's lap. For a patient who is confined to bed, the caregiver may sit at the patient's head and place the head on the lap. When body and arm movements need controlled, the caregiver can sit beside the patient, lean across the patient's chest, and hold the patient's arms against the body with the elbow. The hand of the clinician's restraining arm can hold the mouth prop, retract, or do whatever is necessary. Two people. If any of the positions previously mentioned, the parent may need the assistance of a second person to hold the arms and hands or otherwise restrain the patient. A small child may be placed across the laps of two persons seated facing each other. One stabilizes the head and brushes and flosses while the other person holds the hands, arms, and legs as needed. Group and service education. In-service programs are provided for teachers, registered nurses, other health professionals, parents, and volunteers in school and community preventive programs. In extended care instructions, many patients are unable to care for their own needs and may require total care, partial assistance, supervision, or regular reminders. Dental hygienists can provide in-service education sessions on oral health measures for those who provide daily personal care for others. Preparation for an in-service program. Planning. An in-service program needs careful planning. Objectives are defined in writing and serves as a guide to for preparation and evaluation. Effective learning materials are clear and to the point, interestingly presented with appropriate visual aids and stimulating for learning. Staff concerns are recognized and addressed during the program. Initially, basic preparation includes learning about the functioning levels of the patient and assessing the procedures used to the oral care. A survey of the biofilm control materials and devices available in current use. Methods for labeling or storing individual brushes and the frequency of use are important. The dental hygienist invited to the institution for the specific purpose of presenting the workshop can arrange a pre-workshop visit to observe and get to know the caregivers and the patient needs. Use of patient records. Health Insurance Probability and Accountability Act regulations may restrict access to individual patient records. Gingival Biofilm Index. When the dental hygienist is providing hands-on instruction for oral care, use of a gingival or biofilm index can provide a baseline of information from which progress can be evaluated. The caregiver could carry out the daily biofilm program and see the changes that take place by comparing the before and after results. Continuing participation and receiving feedback of successful biofilm removal can be provided real motivation to caregivers. Program content. An oral health in-service program will be more successful if the content presented is based on the assessment of specific needs identified by the institution, patients, and caregivers. The content could include oral self-care as motivation of self-care and may contribute to caregivers prioritizing the oral needs of the patient. Facts about cause and prevention of oral disease. Basic information about biofilm, its formation, and how gingivitis and dental caries development are important to most groups. The progress of disease from reversible gingivitis to severe periodontitis can be explained, as can the process of dental caries. The concept of prevention through biofilm control, fluoride, dietary control, sealants, and early treatment for restorations is carefully presented. Handout material and colorful visual aids promote learning. Oral inspection. Caregivers can be trained to notice changes to the oral mucosa during daily cleaning and to report to the appropriate person. Techniques of mouth care and disease control. Caregivers working in pairs can be more efficient, particularly in the care of challenging patients. Individualized plans can be developed and training provided for caregivers to address specific problems relative to each patient's needs. Information to teach caregivers about dental biofilm is discussed throughout later chapters. The use of a portable bedside suction unit for removing debris from the patient's mouth is also mentioned later. Fluoride application techniques are also outlined later. Denture care. Procedures for denture care and the mucosa under the dentures are discussed later. Xerostomia relief. Instruction for caregivers include how to use a swab with saliva substitute to provide relief for certain patients. Denture marking procedures. All dentures are marked for patient identification. The techniques for denture marking are outlined later. Records. Oral care documentation for each patient is essential to evaluate the success of the in-service presentation. During instruction, the staff can learn appropriate information to include in each patient's records. Documentation for oral care provided by a caregiver may include implement and materials used, self-care instructions provided, successful techniques, and suggestions for future instruction. Follow-up. After caregivers have tried their newly learned procedures, an opportunity to have questions answered is provided. Direct observation of techniques performed with and for the patients. Advice concerning oral problems of particular patients and corrections when necessary can motivate and encourage both the patient and the caregiver. The hygienist disclosing and recording the biofilm for comparison of scores before and after the program can show the progress being made. Continuing education. In residential care facilities, individual instruction is provided for each new employee during the orientation period. Periodic in-service presentation for updating all employees can be provided. Questions and problems can be discussed, and plans can be introduced for changing a certain procedure based on new research evidence. The dental hygienist with a disability. Disability is not necessarily an obstacle to dental hygiene licensure and provision of clinical care. Adaptive technology, tax incentives for accessibility construction, and creative thinking can facilitate necessary workplace modifications. Additional dental hygiene roles such as manager, advocate, or educator may provide employment opportunities for the dental hygienist with a disability. Documentation. In addition to the standard information recorded for a patient visit, documentation of care provided for a patient who has a disability includes individualized information about the patient's condition or level of functioning that will affect modifications needed during dental hygiene care.